may vary is if I am aware I'm coming for TAH. We need to share that bill with the private insurance. But what happens is that the person who paid 500 will not be discriminated who pays 500 so that they can have similar services without suffering out-of-pocket expenses. So that is provided for, and if you've gone through that, through your branch, you can actually say these requests have been and are approved. Our contract says we should be paid this much. This is what has been approved, and it is usually, with no issues, it is usually reviewed to the right contract amount. So that could just be because there is someone who is being paid differently for the same procedure. Tonsillectomy, there are people getting 50, there are people who get 60, there are people who get 65, there are those who get 75. So I could just assume or approve for you 65, and your contract actually reads 75. So you just send back and say, no, my contract says it is supposed to be 75, and it will be reviewed to that much.
Asante case manager. I can see you're handling case by case. So probably you can hand over the mic to Halima. A question comes in here. The new contracts can only be discussed after the month of June 2022. New contracts can only be renewed then. What happens to doctors? What happens to investors? What happens to healthcare providers who have gone out of their way to begin their facilities from last year, between now?
Empanelment process, it's a continuous thing. We have facilities that come on board. We have those ones that have just been gazetted and are waiting contracting. We have some, the majority that are existing already have a running contract. So we handle them as they come. Like there are some rights now, the board is sitting to empanel them. They're the ones that we gazetted and were accredited last November and gazetted, and now we are giving them contract from next week. But what happens is now for the next 6 months until we sort out the contentious issues in the current cycle of contract, we'll be giving them the previous contract, the one that has been extended, so that the period is going to be about 5 or 6 months until the next contract takes effect. But we are contracting them, so by next week they'll have their contract there, and then by next week the board will also sit for the ones that the board paper that is already going on, that has just been. So it's basically a continuous process. Nobody is left out of any process, whether it's the empanelment or the contracting. So we always cater for the need as it arises.
Asante, asante.
So if we have a contract in force, the mutation of an existing contract is what may not be possible. But if you are coming in as a new provider, we will give you a contract on current, the one which is ongoing, until June 30th, after which we either issue an addenda or we mutate, depending on how the engagements we are having with the associations is going to come. So we'll just tell you we are extending, but on new terms as dictated by what the associations and the NINI are going to come up with.
Asante, asante for your great responses. I see time is not on my side. I'm forced to cut short, but I not cut it short abruptly. I will, for the members, as I began the conversation amongst ourselves, so members of KAPH, we are going to have a closed door members meeting, which is now going to address some of the contentious issues coming up here, and there are many more down in there. We can feel that they're not fully answered. So relax, just hold on to your questions. We're going to answer them during the members brief, and that's going to be a closed door meeting. So we will assure you that all questions, case manager will not spot Chair Ladnan and say that is case Ladnan. No. Case manager will be told that it's all about Kenya Association of Private Hospitals. So let's talking a lot about challenges. And yesterday, the chair KMPDC mentioned that let us stop looking at the challenges. What are the opportunities that lay ahead of us? What is your parting shot, and what are the opportunities that you believe and feel lay ahead of us?
Yeah, I think I focus a lot on the challenges. In terms of opportunities, I think moving to digital claims and e-claims actually is a positive thing for NHIF and for other insurances. It at least guarantees some transparency when knowing where is your claim, which we previously didn't have with a lot of the other insurances. As well, it's faster in tracking the payments and even in reducing the amount of labor and workforce we need and the cost of delivering these claims ever so often to the different insurances. So I think just the digital transformation that is happening in the insurance space right now, ensuring that even in future, instead of having physical claim forms, we move to a point where we are having digital claim forms, that would be a positive thing for the industry. The other thing that I think MTIBA would have been useful for, and a couple of the other banks, is they have been providing products based on invoice discounting. So having more care facilities during the delays that we have with payments from the banks and everybody else without necessarily needing the healthcare provider to have a security would also be a positive thing. I remember Family Bank mentioned that they have a product that they're rolling out. If more banks act, that would be very useful.
Asante Daktari. So probably that's an opportunity towards the banking faculty that is here with us. Wakili, speaking from a legal perspective, what are the opportunities that you feel that we need to tap into them as a regulator and perspective?
Yeah, thank you very much. There are a flurry of opportunities, but the one I'd like to state is this. Of the over 14,000 health facilities in the country, 58% are private hospitals. About 34% are public, 8% faith-based health facilities. You have a say, you have a 58% stake. When 58% stake when in Kenya. Get yourself to the table of making decisions. If you find there's no seat for you, pull your own chair and make sure your voice is heard as private hospitals. You have a stake with the delivery of UHC.
Asante, Mr. I can see Mr. Chair smiling. Amesikia kwamba bwana makofi ya wakili from KMPDC that you have the stake. 58%, Madam CEO, be able to know that the 58% has the stake towards that conversation. Madam Halima.
Thank you. Thank you so much. The fact that you have a 58% stake in the healthcare sector already tells us that you're actually our biggest stakeholder. But one thing, I've worked for NHR for 16 years. And we are really partners when we are paying you well. We are partners when you are approving your LOUs. But somehow at some point, like the doctor said, it takes two to tango. So when we are in good terms is when we are paying you, and we realize that most of the times when NHIF is mentioned in bad light, you pull back, like you're no longer our partners. And that has been the case with private hospitals and faith-based. But from accreditation and empanelment point of view from Halima, once you come to my office, that is when our partnership, for empanelment, we've become partners already. So for good or bad. So I would request healthcare providers that our partnership should be based on, you have to help us on member education, because you are the point of entry, the point of sale where the patient comes to, our members. So you have to educate them. You have to put them in a position where they are educated about what they expect of NHIF. Don't leave that to NHIF, because we have 45 Kenyans to take care of, and you're our biggest partners. So play your part also, please, and help us be the the world-class social insurer that we want to be.
Asante sana. Madam Case Manager. Give us the opportunities. Don't give us the challenges. Give us the challenges. Is that you feel probably within 2 minutes. Give us the opportunities that you feel that they need to be. We need to now tap into those opportunities.
Thank you so much. With the UHC, the opportunities for all of us are so huge, so enormous in terms of business opportunities, in terms of making our marriage, because we are in a marriage. NHIF collects money. We don't own any hospital in Kenya. We depend on you to actually, deliver the promise we've given to Kenyans that once you pay NHIF, so we really depend on you 110%, probably more than you even think. Because if someone has paid and they cannot access care, then that opportunity for them to stop paying because they don't see the need, and then the image suffers. So kindly, no, we are in this relationship for the long haul. We are not going to divorce anytime soon. Dr. Rao, we are together in this relationship for the long haul, and the opportunities are many. And with those opportunities, what I see happening is the commodities and supplies are going to come down, because now you're not just purchasing a plate for one, or if patient, you're going to have multiple of those with the UHC coming. And so you can also, review your costings around increased numbers of people. That's an opportunity. It's also, this is an opportunity for us to discuss, to talk with each other, to ensure, because it's not about us. As I was saying yesterday to some of you, our relationship is like nucleus of a cell. The nucleus is the member, the beneficiary, who is the one who binds us together. When the nucleus is not happy, whether it is the mitochondria, the lysosomes, whatever is contained, then it affects the health of the cell. And so our focus as providers, as NHIF, should always be focused on the nucleus, who is the beneficiary. To us, we call them member. To you, they come to you as patients, as clients. So we must work together to ensure this is done. The other, seamless provision of services, especially in relation to pre-authorization. Most services in healthcare setting are planned services. Whether we are talking about surgeries, we are talking about imaging, we are talking about chemo, we are talking about dialysis. All these are planned services. They are not emergency. Very few services will be emergencies. So how do we make it seamless so that there will be no complaint a pre-auth was delayed? Because unless it is a ruptured appendix or ectopic pregnant, why, when you plan, why don't we have that request sent early enough so that a review can be made? If there is additional information that is required, it is asked for in time, and the feedback is received, and then we can approve. Dialysis, we do approval for 8 sessions every month. Why is it not possible then for us to do, the time the patient is coming for the 6th dialysis, why can't we request for the next month so that we have enough time to ensure approval is done? The same with chemo. If a patient is coming for chemo, it is mostly either every week or every 2 weeks or every month, and we know that to come again date. So why can't that request be sent early enough, like a week before the patient is supposed to come, and then if there will be any issues that require discussion between ourselves and the provider, they are handled during that 1 week, and coming for their next chemo, it is already approved because we've sorted this issue. If you could help us with such strategies, it becomes very easy for us to ensure your theater services are running seamless, everybody is happy, and when everyone is happy, then we continue coexisting very well. So the opportunities are there for us to exploit, and we are here to support you 100%. But you also will need to support us so that we work as a team. Thank you very much.
Asante. Ladies and gentlemen, a lot of applause to my able panel here. I know some questions have been left out. Those shall be addressed during the members' the members roundtable. So allow us to now, probably I will invite the CEO, KAPH, to probably award our panelists for today. The CEO can stand in a group photo to probably speak about the opportunities that have been missed and the challenges. And one of the greatest things from end to end we have realized is the digitization of the process. That is a great opportunity for all of us to be able to tap in. Just before you give, allow us to. Yes. With Wakili, with Madam Case Manager. Wamesema tuko katika ndoa ambayo hata kadhi mwenyewe haezi vunja. Hii ndoa ni hadi milele. Wanachea Wakili who has said it is a democracy for the people, by the people, with the people. Asante. So ladies and gentlemen, to probably even be able to deliver some of the solutions, to be able to go to some of the solutions that have been proposed, some of the opportunities that have been missed, and that we do need to propose during this convention. I want to welcome one of our great sponsors, and we specifically tailor-made this and ensure that they present at this moment so that they are able to probably give the opportunities and give the opportunities that are supposed to be given. Ladies and gentlemen, allow me to welcome none other than Savannah Informatics. Makofi yao tafadhali.
Good morning, everyone. I don't know if it's morning or afternoon. I hope you're well. So, for the purpose of our presentation today, I will just cover briefly the role of technology as we aspire towards universal health coverage. So that is what I will discuss majorly. And then at the end, I will just showcase some of our products and how we're helping the private health sector assisting the universal health coverage ambitions. Okay, so just a brief about me. I'm Joy Kiguta. I'm the Chief Commercial Officer at Savannah Informatics, where I'm in charge of the relationship between providers and the different pairs that we have, currently the insurance companies that are working with us, and also seeing into the future, how can we make the healthcare sector more efficient, and especially for the providers that we serve. So for today's agenda, and for the purpose of this presentation, what I will be covering is universal health coverage, and what are our aspirations as Kenya, and what are the challenges that we're facing, and how technology is an enabler for us to achieve our UHC ambitions. And finally, looking forward what we can do together as different stakeholders in the healthcare sector. So looking at UHC in Kenya, at the start when we were launching UHC, we wanted by 2022 all persons in Kenya to be able to use essential services they need for their health and well-being through a single unified benefit package without the risk of financial catastrophe. So in short, there are three elements that we have when we're looking at universal health coverage. There's the aspect of cost. We want to reduce the cost of getting healthcare and also providing healthcare to the normal mwananchi. Then the other thing is the aspect of access. Everyone should be able to access or get healthcare, the healthcare they need when they need it and where they need it. And then the final thing and the most critical thing is that we ensure that we're providing quality healthcare to everyday mwananchi. So when we're looking at the aspirations, the challenge here when we're talking about universal health coverage and what we have seen with different developing countries and emerging markets, it's very difficult for us to balance the three. Provide coverage, making it accessible to every person in our community, and also lowering the cost. So what happens is many people have decided or have been able to tackle two of them at the maximum. So providing low-cost healthcare, but it's not of quality. So what use is it to us if it's not quality healthcare? The other thing is people have been able to increase access, but is it also quality healthcare? So what we are looking at when we're talking about technology as an enabler to achieve our UHC aspirations is how we are able to come up with solutions that will tackle each of the three aspects of UHC. So access, quality, and cost. Now looking at technology, what is technology in healthcare? So there's the usual diagnostic kits and such like things that are part of technology, but for the purpose of this presentation, I will focus on the two. We have telehealth and mHealth. So telehealth is what has been defined as telehealth requires access to only telecommunications as the most basic element to provide health. So this is in terms of foundational or basic things like your mobile phone, internet access, concentrate as telehealth. Then the other one is mobile health, or generally defined as medical and public health practice supported by mobile devices. So this will bring in aspects of increasing access. We are able to get even to the people who are in the most, marginalized communities or in far-flung areas are able to access healthcare without the need of individuals or doctors being in those areas. So then the question is, how do we leverage on technology to achieve UHC? So what we have is how we are able to use technology to provide the three aspects for UHC in terms of, So in terms of access, quality, and cost. So when we're looking at access, the major issue, the major challenge we have when it comes to access is geographic and transport barriers that do not enable people to go to where, they're not able to access services, since services are usually mostly in the centers or in the towns. So what happens to people who are outside of these areas where the hospitals or clinics are found? We need to come up with technology solutions that are able to tap into this market. Then the other thing we're suffering from as a nation is provider shortage. We know that we are well below the WHO recommendations in terms of the doctors, nurses. The healthcare workforce is very limited, as we all know. So we need to also figure out solutions that will couple these two, geographic and transport barrier, as well as provider shortage. Then when we're looking at quality, quality is just centered around the people. Having the people at the end, at the back of our minds when we're providing technological solutions or software solutions when it comes to healthcare. Then the other thing is effectiveness of care. So we do not want to provide care and then at the end of the day, our patients or our members or the people in our community are not well. What they have gotten is not what they require. So we need to think about effectiveness of care. Then the final thing in terms of quality is patient safety. So we've heard about how there's pharmacovigilance and such like things. These are things that need to be critically looked at for us to achieve UHC in terms of quality. Then the other thing now, in terms of cost, we have the cost of care and the efficient use of resources. So we've had a lot of conversations around the cost of care, the licensing, the cost of drugs and such like things that need to go down. But then on the other side is the efficient use of the resources that we have. So in terms of the private hospitals and what we're seeing currently is that we want hospitals to concentrate on their key business or why they are in operation, which is to provide healthcare to everyone, quality healthcare to everyone. So how do we make the system or the healthcare system in general more efficient in the use of the limited resources that we have? We have limited healthcare workforce. So how do we make use of that, the small numbers, while still at the end of the day trying to provide access and, as well as quality healthcare? So there are three foundational types of technology that have been put across, and small other software or technologies have come under them. So the first one is telemedicine. So with telemedicine, without looking at it in a very complex way, is how do we use our phones for people to access healthcare. So I know as healthcare providers, as doctors, as clinicians, we do get calls from, let's say, our relatives or our friends telling us that, oh, I'm not feeling well, oh, could you tell me what I should use, and such like things. In the simplest form, that is telemedicine. But it has not been, there is no way for you as a healthcare provider or you as a doctor to be able to make a return out of that. Although we're doing it for community benefit, there's a way that you can tap into that market where a simple conversation between you and anyone else in your community can provide quality healthcare along the continuum of care. The other thing is access online doctors. So even through telemedicine, we can go a step further and provide online platforms where doctors can be able to be reached by people in all over the country, all over the region, with just a click on the telephone. Then the other thing that telemedicine has been able to achieve is reduce time associated with seeking care in remote areas. So as opposed to people coming from the remote areas to the towns to get care, they can dial in or they can call a medical professional and then they can guide them on what needs to be done. So we've heard of cases where people travel to Nairobi because they need care, cheaper care. At the end of the day, it turns out to be more expensive because they are spending on the transport, they need to look for somewhere to spend the night. So at the end of the day, the cost of care becomes larger than what they had anticipated. It goes beyond just paying for your surgery, for example, or paying to see the doctor or a specialist. So having telemedicine in use so that people can be able to access all the services from wherever they are when they need it. Then the other thing is health information systems. In terms of access, so what we have seen in our industry is that people want to have access to their care. They want to have knowledge on what has been done along the continuum of care. If you look at, let's say for children, the vaccination card is something that parents really walk around with. As opposed to having the vaccination card, a physical card, why not provide that information to, let's say, the mother or the father on the phone so that they can be able to access it anywhere and wherever. I have seen also in hospitals where people walk around with files of all their medical encounters. So all their medical reports, all their claims information, they carry it around in folders. So why not provide a solution where patients or individuals can be able to access that information on their phone, and if they go to a new provider where they have never been, they can be able to transfer that information. They can be able to transfer that information to their new physician. So looking at solutions that will enable that will make the life of we as a citizen and also as practitioners or doctors and such like things to access such information. This is through health information systems. Then the other thing that it will help us do is in terms of quality. If me as Dr. Joy, one day, I get a patient and they're able to share with me all their information for the last 10 years, and I'm able to see the continuum of care and see if an issue has been a recurring issue over their life, and we are able to come up with a solution so that those episodes of care stop, and people are able to provide quality healthcare, because we have the whole continuum of care, they have all the data that they need, then that is something that will see us achieving better quality of care that is given out to individuals. Then the other thing is health information systems also ensure drug prescription management. So if you're able to keep a record of all the drugs that have been prescribed and that have been taken in a system, and an individual is also able to access all this information on all the drugs that they have been able to access over the last 5 years, for example, and also the hospital is able to see that, yes, I prescribed this information, these drugs to Joy, but Joy has not yet come to pick them, then what do we do after that? We're able to provide information when it's needed most. Then in terms of cost, health informations help reduce the cost. So instead of stocking drugs as a private facility, stocking drugs that are barely used, like keeping large amounts of drugs that are not going to be used, you're able to see, given the certain population that you're serving, these are the drugs that are used, that I prescribe mostly. So this is what I will keep. I will see that there's a need for, let's say, gynecologists in my facility, since I'm seeing so many women who are coming with different complaints, and we have to refer them to another facility. So depending on what your needs are, you're able to reduce your transaction costs with health information systems. Then the other thing is quick access to holistic patient data, which I've spoken about in terms of having the patient information. Then the third thing that we can have with technology for us to achieve UHC is tracking and notifications. So the first thing is, for those who are in far-flung areas, telemedicine can be able to track and notify, you can be able to track and notify, you can notify a healthcare provider of episodes of, let's say I'm not feeling well, I'm having such and such symptoms. This can be able to be notified to the different healthcare facilities, and then they can tell you what you need to do, whether you need to go into hospital or we can provide you with care remotely. Then the other thing is, in terms of quality, personalized health information. So we have information about whether you're a diabetic, you're hypertensive. We're able to give you information, let's say on a platform, on our telemedicine platform, that will keep you notified on what you need to do as a diabetic or a hypertensive patient. Then the other thing is more patient data-enabled service. So data-driven services, as opposed to just saying that I am providing services to my community. So having data that will back up the services that you'll need. As I said, if you need a gynecologist in your area, if there's no gynecologist, what do you do? But you have data that has fed into your decision making. Then there's also monitoring of patient conditions through apps or through just feeding in your data. For example, if I'm hypertensive, I can be monitoring my BP, and that is able to be sent over to the healthcare provider, and the healthcare provider can be able to monitor my condition and tell me, now your BP is getting too high, do such and such. So that would lead to quality healthcare. Then the other thing is reduce costs. So we have cases where you have told a patient to come to hospital after a month. So before that month has reached, you are able to notify the patient that your appointment time is reaching, kindly show up. So you are able to prepare in advance, and the patient is also made to prepare in advance to come for their clinic appointment and such like things and such, and so there are reduced costs. Then the final thing is real-time and automatic patient updates. As I said, you're able to do that through a technology platform. So I've gone through this. I'll just skip through it because of time. So what do we take away from this? As we have been told repeatedly during this conference, the private health facilities contribute to almost 60% of healthcare provision in Kenya. And so we have, as private facilities, we have a responsibility for us to achieve universal health coverage. And universal health coverage is not possible without taking into consideration primary healthcare. As much as we own large healthcare facilities, we have a responsibility, or we have a way to tap into the lower segments in our communities through technology. So for example, many of us do outreach campaigns where we speak to different people in our communities, but do we have a way to continuously capture that information, have the information of the people who you saw the last time you had a community outreach program, and then feed that into your database as a hospital. So having technology or having digital solutions that will help you build up on the primary healthcare provision side of things will also help your organization grow. Then the other thing that technology is there to assist in is early detection, early diagnosis and health education. So as in the cases of non-communicable diseases, where we're able to screen early and keep that information on which patients we have screened and those who we have seen, for example, are pre-hypertensive, and have health education given to all those patients that we see or people in the community before they become patients actually. Then the other thing is through technology, you're able to reduce the fragmentation of patient information. So for example, today I'll come to Nairobi Hospital, tomorrow I'll go to Ladnan, the other day I'll go to Metropolitan, but no one has the information about the services that I have sought in other facilities. But if we're able to provide a solution where this information is carried by the patient, it's their information, and at their will they are able to share that information with whichever health, and it will reduce the fragmentation and also increase the quality of healthcare that we are able to do. Then the other thing is increasing access to financing. So we've spoken about how out-of-pocket payments is something that we want to do away with. I mean, it's leading people to catastrophic health expenditure, pushing them into poverty. So how do we come up with solutions where people are able to access financing to be able to get into health insurance? So solutions that can be coupled by digital technologies. If you're able to buy insurance on your phone, or we're able to come up with premium financing so that you're able to access private health insurance, is something that would also, at the end of the day, increase the number of people who come to your facility for care, and you're able to get paid for that. So what is the groundwork that needs to be done for technology to be taken up, to be fully taken up in Kenya? So we have regulatory and legal frameworks that have already been implementation part of it, and the use and also knowledge being shared with the different stakeholders on what the legal frameworks are when it comes to telehealth or e-health. Then the other thing is to enable since private healthcare providers are the ones who are in touch with most of the population in terms of healthcare provision, it would be important that we get into a collaborative framework where private sector collaborates and comes up with innovative workflows that would see us develop technologies that would see UHC being attained. Then the other thing is to define an impact measure framework. So as much as we want to spur innovation in terms of technologies and software, we need to measure the impact of all these things that are coming up. We have gotten into a scenario where many people, yes, are coming up with innovative ideas, but they're not. So what is the point of coming up with an innovative idea and leaving it to just a few people to use it, as opposed to benefiting the whole community, if we're really serious about UHC? And the other thing is scaling. Scaling is very important, making sure that as much as we want to come up with innovations, make sure that they are commercially viable and they can be able to be scaled up. So finally, just a brief on what Savannah is doing to help with UHC. So Savannah is trying to bring the different actors in the healthcare space. So we have the private hospitals, the public hospitals, the faith-based organizations, the patients, and the different payers who pay for healthcare, whether it's insurance companies, whether it's employers, whether it's through grants or international organizations. So we bring them together through different products that we label as Slate 360. Then in terms of the patient, we try to come up solutions that will keep patients engaged. So through our Be Well by Slate 360 application, where you're able to engage and see your claims history, you're able to see your care history from different hospitals and what you got prescribed, your claims information, all of that is available at your hands. Then the other thing is we are working to make sure that more people are able to access health insurance. So what we have done is to partner with a financing company so that we're able to provide premium financing where people are able to get health insurance and pay on a monthly basis for very low premiums, but above NHIF. So over and above getting your NHIF insurance that is very easily accessible. So that is what we're doing in terms of Savannah and technology. I don't know if there are any questions or comments. Yes.
Thank you very much for a very stimulating talk. Informatics, essentially you're talking about communication. And you're talking about digital communication.
Yeah.
You have covered everything, but we need to segment health in its various compartments. The least thing we are talking about here is actually human wellness and health. We are referring to disease, we are referring to facilities, we are referring to treatment. Is there a room for actually promotion of wellness and being healthy? If you had dear Judith Otele telling you the amount of money she has to authorize to hospitals, it is not small. You needed to ask her, which are these conditions which make her give out so much money? There's a lot in terms of orthopedic surgery. There's a lot in terms of dialysis. There's a lot in terms of brain surgery. If you track these things down backwards, where in the continuum of care, and you said continuum, I'm quoting your words, where in the cycle and continuum of care would it have been logical to put emphasis? You see, we're trying to solve a problem like putting old wine into new bottles. Oh, no, the other way around. New wine into old bottles. What happens? It bursts, isn't it? We have an old structure, and we are struggling with now trying to make. And in trying to make people well, we're trying to cooperate with the old structure. We need to change the emphasis or anchorage of health from where we are making emphasis and we're making all this talk to the household. Health should be in the household. Everybody should know the level of blood group. They should know their level of and blood pressure. And actually, if you redesign the system, that a lot of this should happen within that system, but augment it with technology, right? And technology does not only mean technology or digital technology. Even the invention of equipment, which are handheld. For example, you can now do handheld devices for scanning at the household level. just self-managed scanning, and upload it in the system, and it can be read somewhere, and they can communicate with you. But this is the area we are not making the necessary investments or the necessary pitch to change and revolutionize health. We can only revolutionize health if we move to the household. It's about nutrition, it's about lifestyle. I'm sure in this room there are people who are struggling with diabetes. It started somewhere. People struggling with blood pressure, it started somewhere. People started struggling with cancer, it started somewhere. But we are not giving the right understanding, and that is what would be universal. So we need to rethink of the structure and anchorage of healthcare while still using the technology.
Asante, Daktari. Asante. So, Judith, over to you.
Great point that you have made. And what we see is underlying with that is the lack of knowledge, even on the household level. How do we communicate the need for us at the household level to monitor our health, to know what health means, and keep a track of our health before we get sick? So the funny thing is we only talk about health when we are sick, when we have our blood pressure has spiked. That is when we'll run to hospitals, or we'll run to Google, for example, to know what to do. So feeding that information down to our households, down to a single individual to know what health means and how is something that is very important. And also taking into consideration the different things that are needed to monitor health, the tools, the BP machines. There's a project we ran, I think it was in 2016, 2017, with Ladnan as well, where we were able to reduce the cost of even checking blood sugar and HbA1c, such like things being accessible to normal mwananchi so that they can be able to take care of their health on a daily basis is something that we really need to think about. But as you said, it's a whole transformation of the health and seeing the importance of health as opposed to sickness.
Asante sana. Any other question, probably, as she winds up? To Madam Kiguta. That's a very engaging discussion, in that, are we including primary health care into the conversation of innovation? Are we able to include primary health care into the conversation of innovation and technology, data management at the primary health care level? So ladies and gentlemen, so that we don't run away from that conversation of providing solutions from the great panel that was here this wonderful morning. So allow me to welcome none other than our Wakili Michael Onyango to make a presentation on behalf of KMPDC. Makofi yake tafadhali. Amesema he is for the people, by the people, with the people. Wakili, walio mbele yako wako nyuma yako.
Thank you very much, Bwana MC. This is a slide there. So today I want to do things a little differently. I just don't want to do the conventional slides, PowerPoint, questions, lunch. I'd like to do it a little differently. Just I'll do brief presentation, not so many slides, but I'd like us to do this presentation together. I want to speak on some medical legal issues that affect hospitals, but I want those medical legal issues to come from you. I want us to discuss them. You just shoot from wherever experience you've had. Ask us questions. I know I'm here with my very able boss, Dr. Abdi. Atanisaidia mahali imekuwa ngumu kidogo. He has become a pseudo lawyer since he came to the council. So okay, thank you. I think I've been introduced enough. I'm the Cooperation Secretary at KMPDC. My presentation will be focused on three areas: establishment, structure of the functions, just know what role the council plays in this conversation. Then again, I'll just give key information to further set the climate, and then we'll do, as I'd mentioned, some medical legal issues from participants. Now, the functions of the council, as you can see there, I want to focus on those that are relevant to health institutions. If you go to section 4 of CAP 253, they are well enumerated, but I'll just highlight in red those that are pertinent to this convention. As you can see there, inspect and accredit new and existing institutions for medical and dental internship training in Kenya. Internship training is done in your institutions. If you're a private institution and you're doing internship, you need to be your institution needs to be recognized as an internship training center by KMPDC. There are these others, licensed eligible medical interns, register practitioners. A key one here, a key function is that we register and license health institutions. So all health institutions that offer healthcare services within the bounds of the Republic of Kenya must be registered and licensed by the council. We carry out inspections. There are three main types of inspections. We have pre-registration inspection. This is as you start off, just to ensure that you have the minimum standards. We have the scheduled or routine inspections that are done county by county or region by region. And last but not least, we have the investigatory inspections. Those are the usually not so good ones, but they are usually to find out and audit any processes that may be within your health facility. And under the investigatory one, you can see we take disciplinary action where need be, but we also have alternative dispute resolution. We just don't go for the big stick. We try as much as possible to do what is called supervised regulation, not the police kind of regulation. CPD, which are undertaken in your institutions, and then issue certificate of status of your institutions. When it comes to medical legal issues, Section 4AB establishes the Disciplinary and Ethics Committee, which Dr. Abdi Mohammed is the chair. So he's the chair of a member committee of about six committee members, and he's the one who stewards that committee. Key information when it comes to cases. Since 1997, we have had a total of 1253 cases lodged at KMPDC. And you can see the time growth there. People are becoming more litigious. They're becoming more aware of their rights. They're becoming more aware of Article 43, in which it states that they have the right to the highest attainable standard of health. This is now, and this right and its effecting of it has been left to the hands of the state. It is the duty of the state to ensure that Wanjiko receives the highest standard of care. You can see as at 2022, today as we stand here, already we have 14 cases lodged at the council. Like I'd mentioned before, we try to do alternative dispute resolution. We know sometimes people just disagree. Sometimes maybe it was just an issue of miscommunication. And we, as the council, have been given the power to bring these two parties together, the patient and the hospital. To bring them together, we sit down and we say, we don't have to go through that very rigorous process. Come, let's sit down, let's come to an agreement. That is given to us by CAP 253. Breakdown of how and which discipline things go wrong. You can see the 4 major disciplines and how they are presented. And I think as part of a conversation that we've just had, you can see financial is number 4. And like I said yesterday, when we're having this discussion about UHC, we always ask ourselves the definition of UHC. access to quality health care without financial ruin. So this is already an indicator that some Kenyans who receive health care are feeling that they are either going to financial ruin or something was not done right. That does not mean that all the 111 matters went against the private hospital. That's just the total. Sometimes when you come to the council, we'll say no, the hospital did what it was supposed to do and charged as is fair. Kindly go and agree on how to clear the debt, because at the end of the day, as a council, yes, we have to protect the public, but we also have to protect investors. Like I said, 58% of hospitals are private. We also have to consider that this is money that has been invested. And this is a wider conversation that the ministry is also having on medical costs. The process of disciplinary inquiry, anybody can lodge a complaint. And when I say anybody, we can even pick it from the media. So anybody can lodge a complaint at KMPDC. And we can also act on our own accord. Dr. Abdi, many a times he'll be watching news and he calls me at 10 and tells me, have you seen this and this? Do something about it. And by virtue of that, a case has been lodged. Thereafter, once a case is lodged, we undergo triage, because not all cases fall under the mandate of the council. Some time back, someone brought a case of a certain doctor promised to build a tank for her, but the doctor has now run away with her tank money. Can you deal with this matter? That has nothing. Is there a doctor-patient relationship there? There's no doctor-patient relationship. So for the council, if there's no doctor-patient relationship, we'll just tell you kindly either go to the police or go to court or go to debt collectors. So this is the triage. This triage is also to protect hospitals so that frivolous cases are not brought. So once it is lodged, the file is opened, and a report from the respondent to you. We have to hear your side of the story. That is as per the Constitution. Any complaint, you must hear the side of the story of the person who has been complained against. Once you do so, and we get your response, we share it with the complainant, and we tell them here, Dr. Liz Gitau's hospital has said this, what do you have to say about it? And many a times you find complainants saying, oh, okay. And they say, if that's the explanation, makes sense. So when you don't respond to demands from the council, sometimes it works against you. Because maybe your explanation will be so clear that the complainant drops the case. So once it's done, that is done, we copy of the response is forwarded to the complaint for reply. If there's still issues to sort out, we now forward it to Dr. Abdi's committee for determination. And if worst comes to the worst, and your issue was so gross, we now refer you to the tribunal, where you run the risk of being deregistered permanently. And when I say permanently, it means permanently. You go and look for another profession to undertake. That is as per Cap 253. Can a hospital be held liable for medical malpractice of one of its employees? Yes. There is what is called in law the principal, agent, and third-party relationship, where the hospital is the principal, the employee is the agent, and the patient is the third party. So once you employ someone, you can't run away from them. As long as it is proved that it was not just about negligence, but there were some system issues that contributed to the negligence, your hospital will be tied in under what is called in law vicarious liability. So this is just to say that why I'm raising this is because one way to protect yourself is to employ qualified, registered, and duly licensed professionals. The moment a case is brought to us and the practitioner is not registered or licensed, we now go to the proprietor and the medical director of that institution. That is a criminal case. You have touched a patient. As a non-medic, that's criminal. So now we forward you to, if I touch a patient and I treat them in Dr. Abdi's hospital and it's found out by the council, they send me to the police. It's a criminal offense. But if it's under Dr. Abdi, now Dr. Abdi's hospital will be brought to task as to why it employed someone who is not a professional. And why is this? It is because when Wanjiku walks into that health facility, they have given the trust to that hospital that everyone here is capable of doing what they're expected to do. And you break that trust when you employ people who are not qualified, registered, and licensed. I want to stop there. And I just want us to pick 3 issues, not more, not less. I don't want to be the one to further drop your glucose levels. We have lunch. I just like 3. Bona MC will just assist me with this. Just 3 issues, and then we can discuss them here and see what are your experiences, what have you encountered, and how would you want me to probably advise you. So I'll throw this to the floor.
Members hawana maswali.
Kuna swali, scenario. Yes, we have one here. Another one, one more, 1 or 2 more. Yes. The middle back area. I think we can work with those 2. There's another one? Yes. So we have 3. Thank you.
Thank you, Michael. You projected the number of cases. Obsgyne is top of the list. Could you tell us some of the complaints you receive and why you think that this is with the most complaints to the board?
I think I'll just take them one by one. So Obsgyne globally is quite a major issue. But we find a lot of some of the developed world, Scandinavia, have managed to reduce this to, I think, a death of 1,000 per. I'm not quite sure of the statistic. It is something Kenya is moving towards. If you look at all the campaigns that have been launched, Beyond Zero and all the likes, it's all driving towards that. And I guess that is why we are urging mothers to go and seek obstetric and gynecological care in health facilities where people are trained. So not that in the home, it's done in the home, and then when things are bad is when you go to health facilities. That being said, I think it's really sad that this is the top, because pregnancy is not sickness. And it's sad that when one person tries to give life, sometimes either both or either lose. And you see, if you're sick and you have a stomachache and you go to a facility, in the state that, you know, I'm ill, then it could go either way, even though it's 90, 10%, 50, but you're about to give life themselves to hospital. But that is the last time they ever see beyond the walls of that hospital. So it's a very emotive part of it. Then again, like I'd mentioned, there are 2 lives at stake, okay? And of that, I think the highest cause of death, maternal death right now, I think the doctors here can correct me if I'm wrong, is PPH. And the lack of continuous monitoring of the woman during that period. That is one of the issues, and it's why we really need to invest in this area. We are needlessly losing lives of mothers, and people complain. And that, aside from, yes, the numbers are there, the emotive aspect of it drives the number up. Yeah. Dr. Abdi?
Yes, other than the emotive aspect of it, with delivery, things can go haywire within minutes and seconds. You push a baby, all of a sudden, PPH came. So the biggest challenge or complaint is when the facility is not prepared. You either don't have blood, or you don't have a referral system, or you don't have the doctors or the consultants to be able to intervene and take action. So that is one area that as a facility you have to be very careful. If you are doing deliveries, make sure all walk-ins who are delivering SVD will be fine. It can deteriorate. Then the other thing is you don't have enough personnel to monitor or even pick the issues. So you have a nurse or a nurse aide who is not well trained. She nicely documents blood pressure, which is going down, pulse rate, which is going up, and she doesn't think of intervening. And that's someone who is losing blood without being realized. Or she nicely documents fetal heart rate, which is going down. And then when you look at those forms in the hearing, then now you don't even know how to help the hospital. The evidence is very clear of what was happening. It was just lack of the personnel not understanding when they need to intervene. And then you have this person who labored in your facility for the last 24 hours, and then at the end of it you have fresh stillbirth. There is no way to explain or even console that person. So you need to invest a lot if you are doing delivery, and that's where maternity is usually the highest. And those cases against hospitals, some of them, or I could say, if not 50-50, the majority could be against the individual doctors. So it's the facility and the individual practitioner. Thank you.
I couldn't have said it better. Yes.
Oh, okay. Thank you very much, Michael. My name is Dr. Ruto, member of CAF, and I run a facilities called a Real Group of Hospitals. I have two questions. Question number one touches on your last point, whereby principal, which is a hospital owner. When I started my practice, that was in a public hospital. We used to have paramedical staff who used to do procedures in the hospital. So there was a collaboration between the patient and this paramedical staff, mainly in terms of investigations, surgeries, and one case which was very specific is procuring abortions. So what happens is, at one point, parents are the ones who came to complain that there was a procedure which was done which was illegal. So how far is the culpability principle in such a situation whereby you might not be in total control of each and every second of the activity that happens within our facilities? That's one. Secondly is an issue that I think it has been extremely more currently that you handled at the council, is that the rights of the patients are there, and then the rights also of the facilities are there, especially in terms of finance. You recently, as a council, threatened to cancel my license because of a patient not having ability to pay and not willing to provide a plan how to pay. Because usually they don't know how much, sometimes for emergencies, how much is going to cost, but they commit themselves to pay. So when they're paying, we would commit them, they will come with securities or even sign agreements. But recently, of course, unlawfully, institutionally, you said we release a patient in capital letter unconditionally, and of course you sensationalize the matter in the media. So, of course you are the regulator. The law was on our side, but you can't fight. So it leaves us to say, because I did ask, they say there was a lot of pressure from Parliament. What if we go to Parliament and say we shall revisit? You remember our president said we shall revisit. So I think as a board, and especially as a technical person, we do not want the ambulance chasers scenario in the medical field, because if we open that Pandora's box, it's going to be extremely unattractive for investments in that sector, and it will be very expensive, and Balance makes profits in that area because of the regulator has allowed a lot of ambulance chasing in that area. So what I would urge, you being the technical person, is I think is a matter that you need to address it urgently. Maybe to add into that is that haphazard cancelling and sensationalization and mediarization of what you do, because another facility, a staff to things, they go outside, they perform, and then because that staff is working within the facility, you cancel. You know, it also has a lot of issues on the brand. So beyond the two questions that I did ask, thank you very much.
Okay, thank you very much. I'll take the first one. The issue of illegality, an illegality is an illegality. And if it's done by a professional, it's directly linked to that particular person. How you can defend yourself and prevent you being put in a precarious situation is you having clear systems, clear guidelines, clear protocols, urge your professionals to document, and ensure that communication between these links are done properly. Yes, the case will say that there is an illegal abortion being done at a certain facility. But when you come before us and you'll say, I did this, we had systems, we had protocols, we had guidelines, this particular professional acted on their own accord, you're off the hook. You're off the hook. So do what you need to do. And when you employ this particular person, you employ them and you tell them, this is what you need to do. If anyone crosses any other line, that's where now. But also to further add to this, you see in law, things are not always black and white. Yes, you might put things on paper as a regulation, as a guideline, as a protocol, interpretation of the Constitution, even though it was written by a committee of experts. Who does the interpretation? Dr. Abdi's committee. That's why Dr. Abdi's committee is not robots who pick, was abortion done or not at facility? If yes, punish hospital. You have human beings who, between the black and white, are able to sieve the gray and make a clear decision. When it comes to that, the issue of detention of patients and the like, we as a council were put in a very precarious situation because one, there's policy that has been set by the Health Act as to how healthcare financing should be done, both for emergency cases and also for just the usual payments done. The policy framework. We can advise on policy, but our main job is not to set policy. It is to regulate within that policy framework. Now, sadly, there are some authorities that when it comes to setting policy, some things have not been done. But we can see UHC has been rolled out. Some of this, like for example, UHC, is to address that issue. We would have loved this to have been sorted years ago, but at least we've started with UHC. When it comes to emergency treatment, and someone cannot pay, and yet your facility has been told you should not deny anybody emergency treatment. You cannot deny, there's a difference between treatment and emergency treatment. If you're hit by a car on Agwins Kodhek, which is the closest hospital to bring you? Here. Just because you can't pay does not mean Nairobi Hospital can deny you that treatment. They stabilize you, they make sure that you do not suffer further injury and or loss of life. And thereafter, when now emergency treatment has been given, they can now give you now proper treatment. And one of the things we usually advise people at that stage, organize for transfer. Tell them, okay, this is what, can you handle it? You have been stabilized, okay? But the council just didn't sit back just because there's a lacuna. The around medical costs, detention of patients has been driven by the council, courtesy of Dr. Ivan Jenga and Mr. Yumbia. The conferences, the stakeholder meetings, it's because we are the ones who are usually on the forefront. What are you doing? Calls at 11 o'clock at night. So we want to solve this, and we're not, and it's a conversation that's going to continue, and we hope at some point in the near future, you will not have to go through what you did. And also, Wanjiku will not have to suffer financial ruin. That would be my response.
Thank you. Thank you, Wakil. Thank you, Wakil. Mine is one or two. Now, can you maybe, for the sake of this audience, tell us what happened with an emergency? There was something called Emergency Act, which was supposed to come to Parliament to cushion on patients' cases, and have not been able to settle their bill. Number two, what will you say about the lawyers have become very idle after collapsing the insurances for the cars and whatever it is. Now, the medical people are becoming the next ambulance chasers. They are the ones going to be chased. What will you tell us about what to do and what not to do? Thank you.
Okay. Treatment issue. Article 43(2) of the Constitution states that no one will be denied emergency treatment. This is an issue when the committee of experts was going around the country collecting views on how to come up with Constitution 2010. Wanjiku on the ground said, mimi nikigongwa na gari, nikipelekwa hospitali hii na hii, hawanikubali kwa sababu sina hela. So that became a constitutional issue. That being said, the Constitution told Parliament, set up a law on how emergency treatment will be done. Parliament did that. And if you look at the Health Act, under Section 7, it enumerates what a health facility should do in terms of emergency treatment. And it didn't stop there. It went ahead and created an emergency fund. Because you as an investor, you need to be protected too. It created the emergency fund. That is what is pending. That's one of the major, don't have the emergency fund. It has not been set up by the various authorities. So even the council, as it sits as a regulator, if the emergency fund was there, we would not have to call Dr. Ruto. We want that emergency fund yesterday so that this issue is dealt with. The ambulance and chasing of doctors, I usually advise doctors as much. Don't shy away from politics. Don't let us lawyers make provisions and regulations for you. We are very good at doing that. And we'll pull ourselves to the table and say, we'll do this. When meetings like this are set up, attend. When there's a submission being set in Parliament and people need your opinions, go. When there's a conversation around something that might not touch on you directly, but affects your colleague, whether it's a nurse or a farm tech, don't say, for us as lawyers, you're either a lawyer or you're a lawyer. We don't have criminal lawyer, we don't have civil lawyer, we don't have corporate, a lawyer is a lawyer. But you see, there's the side, that's them. Union ya nurses wanapiga kelele. You see, work together, come to the forefront, because when things pinch, it's everyone in the health sector. That would be my take.
No, just to add on, no, it's to clarify on how facilities can protect themselves. Number one, as Michael said, employ the right people, qualified people. Number two, have your people document, because when you come for those cases, if something is not documented, we assume it was not done. So it's up to you. There's nowhere you can prove that XYZ was done. So teach your people how to document properly and do the right things. As for to the patient, it's always better to communicate. Most of the cases you will find we reach to the level of hearing, then when the doctor comes or the hospital comes and they start explaining to the committee and the patient or the relatives are seated there, it's like they get a light bulb moment and then they say, why didn't you say this before? I understand it's not easy because there's animosity at the beginning always. But the fact that someone has left in haste from your facility doesn't mean you stop engaging them. You need to follow up. And more importantly, please have documents and policies within your facility so that at least your staff are able to refer to, because those are some of the things that we will ask you, whether you have any SOPs, any policies on how those things can be handled. And for sure, if all those things are in place, no matter what happens, because as doctors and as a committee, we understand that there are some things which are beyond. You might have done everything as per the textbook, and there's nothing more that you could have done to prevent or to stop. But that has to come out clearly, and that can only come clearly if you don't have those gaps, like you don't have unqualified people, that you have not documented properly, that you don't have any SOPs. So internally work on your things, and then you, as an association, we need to find an insurance that we can work together, who will provide indemnity. I have seen many times when people are brought there, number one, their insurances are not even represented, they are not even bothered. When a ruling is given, they disappear from the face. They just tell you, look close, XYZ, and they don't pay. So they only are happy to collect your premiums, and then when the time comes, they disappear. So we need to work together and negotiate, whether it's collectively, but so that insurance will feel the pinch if one of our members has a claim to be paid and they're not paying. Because we are giving them money and they say they are going to protect us, and at the same time we are providing services and they are not paying. So you cannot have twice, paying them premiums, and when it comes to your services they are not paying your claims. Then it will not make any sense. Let's come together and push for one unified contract for those insurances. Thank you.
Number one, you said one of the roles of KMPDC is to license training institutions. And this is where quality sometimes is compromised. We have different cadres of healthcare workers. And I want to believe KMPDC is a big brother. how do we work with other regulatory bodies to make sure that these other cadres of healthcare workers, I'm an oncologist, and we have, for instance, clinical officers, medical oncology, a program that is interesting. How do we then make sure that they do what is their role, which will not compromise quality and lead to medical legal issues based on their level of training? Number two, of the cases which are lodged at KMPDC, how many of these cases, what percentage would always find hospitals culpable? Because I realize probably most of them are launched because of financial extortions and interest from, especially those who've lost loved ones. Those are my two questions.
Okay, thank you. Yes, thank you, Dr. Melly. The first question is on training. And because in the life of a practitioner, where do you start? You first train. After you train, you examine. After examine, you register. After you register, you license. When you license them to practice. If they do not practice as per what is expected of them, you do what is called compliance. So for you to get your next year license is anchored upon whether you've complied. And if you are persistent in your mistakes, you discipline. So that's the chain of regulation: training, registration, licensing, compliance, and unfortunately, discipline, if need arise. So if you don't train well, you will register a half-baked person. You'll keep on licensing someone who's not capable. They will always fall into compliance issues, and thereafter you'll have to discipline them. Hopefully, unfortunately, sometimes at the cost of another person's quality of life. So yes, training is a major issue. And the council is only allowed to regulate medical and dental training institutions. That is our scope. And this still ties to that conversation of silo. But this is something we have broken. If you see the conference last week, it was on the harmonization of training across all healthcare workers. The last week's conference was driven by the ministry and KMPDC, because we've noticed that if you have a very good doctor, but you don't have a nurse who they can work with, does that help Wanjiku? No. If you have a very good doctor who is able to do the differential diagnosis and come up with, take this, but they go to the pharmacy, get the wrong medicine, has that helped? If you have good nurses who are taking care and nursing the patient well, but the lab. So yes, we understand that there are issues, and there are teething issues that we have to face. And last week was part of the process. And I urge you, every year, this will be an annual conference. Please be there and put KMPDC to task on implementation of resolutions of those issues. We didn't work alone. We worked with other regulatory bodies. So yes, training is a major issue. Another issue that KMPDC has also worked on is that in the region, we are not alone. We saw with health, what happened in Wuhan came and knocked on our doorstep. So we can't close and say that this is Kenya, let's protect ourselves. Let's not work with anybody else. We are part of the ESC, regulation of medical and dental schools. We actually regulate across board in ESC. We have the Association of Medical Councils of Africa, where we have actually get a lot from. When we come to do our regulation, we pick a lot from the AMCOA, Association of Medical Councils of Africa. Even this disciplinary process that I've explained to you, we got it from South Africa. South Africa shared it to us, and all 30 member states of AMCOA have adopted it. 2 years ago, we reviewed it. We saw it was an issue because we have to learn from each other. There's also the International Association of Medical Regulatory Authorities. Now this is global. Yesterday, because of time difference, we had a meeting at around midnight, again on training. So maybe next time during the convention for CAF, maybe the theme can be on training and see how private hospitals can contribute to that. Percentage of hospitals that are found culpable, that's a very difficult question to answer, but thank you for raising that. We might have to ask our data team to sort of sieve out. Because when a complaint comes, sometimes they complain against the doctor, but you realize that the issue was not even the doctor, it was a systemic issue. Sometimes they complain against the hospital because they didn't know the doctor, only to realize hospital had nothing to do with that case. It was a medical doctor. So yes, we probably have that data somewhere, but we just have to sieve it. But that is why we have, I repeat, a committee that sits down to sieve through the black and white and pick out the gray areas. That, okay, it might look like a financial issue, but leave the hospital out of this, okay? I think that would be my, so I'd request if there's no other question. Oh, there's Dr. Rai, okay.
Thank you, Bwana Nyango. There's nagging questions to all doctors and health institutions. This is the question of accreditation. It's not an old thing in our space. That number one, who is the official accreditor to health facilities? 2, is that official accreditor certified accreditor? And if they are certified, which is the body that certifies accreditors? NHIF at some point used to give letter of comfort. At some point, the council was involved with the issue of accreditation. But from what angle was this involvement? Was it of recognized practice globally with license, with people who are trained in accreditation? I'm still at a loss. Dr. Nyauma is at a loss. Kindly shed some light onto this.
Okay, thank you. On that spectrum of things, the council registers and licenses. And the council registers and licenses a facility based on your application, which is hinged on a pre-registration inspection from the county. So the county does pre-registration inspection. Through that, we come and register and license you to operate as a health facility. And I think it's every Friday, we share this list with NHIF. Now, to go to your question about accreditation, the purpose of accreditation in this context is how you can have NHIF, you can do business, I don't know if that's the right term, with NHIF. Where that got muddied was because it was felt that, maybe Madam Tele can also assist here, is that NHIF was the prosecutor, judge, and jury when it came to that. All that power, right from the beginning to the end. And it got to a point that, because, I don't know if it's because of the big brother status that KMPDC had stepped up, on account of them being the ones who registered and licensed, it looked like it was probably accreditation. But there is a bill in Parliament to actually put that act with us. You've asked, I'm sure, I think we were in a meeting some time back with you on KENAS and the accreditation issue. How this was remedied was that there should be what is called joint inspections. Not just KMPDC, Nursing Council, Pharmacy and Poisons Board, the laboratory people, so that you don't have KMPDC come in January, you have pharmacy come in March, the lab people in August. It's a joint inspection. But when this was rolled out, we realized we left one key element. NHIF. And there was a task force that was formed to discuss some of the issues on this, which I sat on. And one of the recommendations, joint inspections. NHIF has to be part of it. So that as you are saying that this facility is fit to operate, NHIF is also saying, yes, we can accredit you on the same criteria. It hasn't been rolled out yet, I think, because some of the acts, things that had been proposed, I think the Amendment Act or NHIF has just come into force. The amendments and all those things will now solve the issue. So a lot of what was done in the Act were actually a direct result of what we proposed, because we had a team from NHIF and KMPDC and the other regulatory bodies, and we proposed to our CEOs some of those issues, which they took to Parliament and were adopted. So ideally, accreditation won't be done by all those under the facilitation of the Kenya Health Professionals Oversight Authority. So there's a solution that is being sought. At that juncture, I want to say thank you very much. Thank you very much, CAF, for inviting and actually working with KMPDC on this convention. Thank you.
Asante. Makofi ya wakili. Thank you very much for probably driving the conversation and gearing it towards providing the solutions to which. So ladies and gentlemen, without further much ado, allow me now to take us back to the host of this first inaugural convention. That is none other than the CEO of Kenya Association of Private Hospitals. I have been your host and MC. My name is Mbao Gitau. Makofi ya Dr. Elizabeth Gitau. Karibu sana daktari.
Thank you very much. Very simple assignment, just to thank everyone who's been here with us today. I want to begin by thanking the members, the CAF members. It is because you are, and that is why CAF is here, and it is because of you that you've come. Appreciate CAF members. I want to appreciate our partners, and that is Kenya Medical Practitioners and Dentists Council. They have made this event quite useful, giving very significant presentations on medical legal issues, on technology, and even in terms of just ensuring that you have this venue. Michael, want to clap for you. Please receive our claps too. Our other partners, NHIF, were here to speak about payer provider issues, and they were the star convention. I think everybody was hearing NHIF, and they really want to come for the convention. So for the NHIF team, let us appreciate them. In absentia, I want to recognize Strathmore Business School for giving us a very powerful presentation early in the morning on public-private partnerships. Makofi kwao. And our platinum sponsors, I think they have left, but let us appreciate Zain Pharma in absentia. I will read sponsors, and then we can appreciate them together. Hydraulic Healthcare, Centec, and Corp Fleet Limited, Family Bank, Cosmos Limited. I see Susan there. Clap for Susan. She's been our very good partner. Nairobi Hospital, who gave us this auditorium, and they've been serving us very well. Crown Healthcare, are they represented in here? I don't see them, but Crown Healthcare is outside there. They are equipped. Sante, Biomeru, I was told I'm pronouncing it wrong, but yeah. HFC is also here. MTBA, I saw a team from MTBA. Savannah Informatics, they've just made a very good presentation here on use of technology. They were both our academic partner and sponsor. Please clap for them. And finally, before I close, I want to appreciate our members who are also part of our sponsors, and that is Lifecare and is it Orthopedic Limited or Orthomedics Limited? They were our members, but also part of our sponsors. So we want to thank you very much for attending this convention and for ensuring that we are able to host this convention. We look forward to working with you. Last there is Healthcare Africa and Keton Consulting. Let's give them a clap. So those are the people who actually made this convention quite significant, and we really, really want to thank them for their support. And we look forward to having more engagement here nationally and even in the counties. Following this convention, we shall be working with various members. I see Dr. Ruto, we are coming to Eldoret. Dr. Salim, we are coming to Mombasa. And even for Port Florence, you have assured me, Nyanza area, we are coming there to ensure that we have enough membership. Kisumu, Dr. Rai, we know we are working with you from next week to ensure that we are able to get members there. So thank you very much for your support. And our members, let us clap for, not our members, our other participants and friends who joined us today, both online and offline. Let us give a clap to our friends. So at this juncture, I will ask Dr. Rai to come and declare this convention closed. But even as he comes, just to give a mention is that we'll ask our other participants and other friends, they can go have lunch. Dorothy will give you the lunch vouchers. But for the members, please remain behind so that we sort housekeeping issues before you go away. Dr. Rai.
This is a great day. I start by greeting you in the Lord's name. Hamjambo. I believe that tonight it's going to rain. Why? Maybe it's going to snow. Why? Because CAF has put together an inaugural conference. It has one very, very long time. If you heard Dr. Omache talk yesterday about this, and Dr. Nyauma talk about this yesterday. And from now on, it's going to be in leaps and bounds and grow. Because there is meaning, there is something to bring people together. They could not have chosen a better theme. And that theme is universal health coverage. Some people call it universal health care. What this has demonstrated is that in unison and in togetherness, we can achieve a lot. People came from everywhere. The support came from manufacturing companies, health organizations, health informatics, hospitals, consumers, and everyone. And that has brought life into this conference. For now, we are moving together in unison as partners in universal health coverage, and which is a great thing. It's one of the 4 presidential agendas. And as you have heard, that 58% of healthcare is being provided by the private sector. Let's give them a big hand on that one. And I think and I believe it is going to grow further and further. But when we are leaving this conference, apart from the cooperation that we agree to have, I think one thing that we must agree to have is the essence of protection of the resources for health. The essence of the protection of the resources for health, the role played by NHIF is so significant that if we just tweak it a little, we will be somewhere in heaven. Now that role must be protected, for both providers and also the regulators and also the people would like everybody to go with, is the issue of trust and truth, trust and truth, and trust and truth. You know what I'm talking about. Everybody knows where you have lied in life. I know where I have lied in life. And the consequences of all these things. If we are going to protect our health, we need to protect all these institutions so that we are not compromised in our lives and in our health. Let us practice trust and truthfulness, and also encourage transparency in all these things. There's no point to lie, because then we lie and we kill the whole thing. You kill the goose that lays the egg. So those people who are traveling far, be blessed and travel safely. And let's work from today on reorganizing for even a greater conference next year, so that we become the example to all other countries in East, Central, and Northern Africa. May God bless you all. Thank you very much. Those few words, I declare it closed.
Music, please. Some music. Music, please. Some music, please. Ngoma, music. Debe.
Kuna charger.